Well, thank you, Deborah. Good morning, everybody. What I'm going to do is to summarize with a little more, in certain areas, a document which was originally drafted by Lloyd and which I did some revision of, and which is in the website for this conference. I also had input from others, including Meg, and what we aimed to do with that document was to try and update what the epidemiology that had been published since the IARC working group did their review in 2011. I asked the question, why do we now think that cell phones probably cause brain cancer? Remember that the IARC evaluation was to be possible. And the main reason are three important sets of case control studies. Further data on the interphone study, about a twofold increased risk for 10 or more years of use. Continuation of the studies of Hardell in Sweden. There are several showing 2 to 5-fold increased risk after prolonged use. And an important case control study, national case control study in France, Serenat, about a 5-fold increased risk of 5 or more years of use. And all of these emphasize the importance of latency. And indeed, in some of the discussions of the epidemiology group here, we're going to try and pursue that. Now, this was analysis of data from 5 countries in the interphone study. And what they did was to essentially look at the risk of brain tumors in relation to their estimated radiofrequency dose from mobile phones, but particularly they also looked at other characteristics. And one of them was hours of use. Hours of use, of course, is not an exact parallel with the amount of use, but it often is a good surrogate and has been used often in occupational studies. And as you see, there was very little until you get to a group with substantial use where the odds ratio was significantly above 1. And then in the same study, they were able to look at a specific absorption, 7 or more years in the past, related to never regular users. You'll see again we have significant increased risk approaching an odds ratio of 2 for prolonged severe exposure, estimated severe exposure. Now, about the same time, a case control study was published from Europe, a multi-country case control study looking at risk of brain tumors in children and adolescents. And this goes by the name as CEFALO. And they actually looked at, again, the period of use. And you will see that when they did that, there was, if they used their reference as the never regular users in the middle of the slide, regular use had a slight elevation, but it wasn't significant, and none of the periods of use was significant. But then if they used data which they had in their study in a sub-segment where they had collected operator data on the amount of use and looked at the time since the subscription was initiated, they found in those who had more than 2.8 years as a subscriber a significant increase in use. And in fact, this is approaching a significant dose-response relationship. So what was regarded as a negative study had within it a subgroup where there was far less misclassification of exposure. And when you looked at that group, then you found a significant increase in those with the greatest duration of use. This is a graph from one of Hardell's papers, where essentially he looked again at the effect of cumulative use. You've got the 95 confidence intervals. It is, of course, a model application, but what he was trying to convey was increasing cumulative use of wireless phones increases the risk of malignant brain tumours. But in one of his studies, which he looked at the types of phones and the site where the brain tumours occurred, when the brain tumours were near the site where the same side of the head where the mobile phone had been used, or a cordless phone had been used, and Hardell was one of the first people to publish studies in which he distinguished mobile phone and cordless use. You'll see there was significant increase in risk, again approaching an odds ratio of 2, but for contralateral use there was some slight elevation of the odds ratio, but not significant. Now here is this summary of the French case control study. This came from a group that had done in the past a study of the association of brain tumours or various tumours with occupational exposures to electromagnetic fields. The occupational exposure not to radio frequency but to electromagnetic, and then they went on, having found significant risks in that study, to do this rather detailed case control study in multi-centres in France. They described it as national. It's not quite national, but it certainly covered large areas. And what you'll see is that when you characterise exposure in terms of average calling time per month, there was a suggestion initially of increased risk, but when you got to 15 calls or more a month, then you had an elevated odds ratio of 4, which was highly significant. Perhaps even more significant in the group that was in urban areas, as distinct from people in rural areas, you had an 8-fold elevation of use for mobile phone use. And once again, they were able to look at whether the brain tumour was on the same side as the phone normally held, or on the other side. They didn't find significant findings, but it was in the direction we'd come to expect from what Hardell had found. Now, Hardell went on to reanalyze some of his studies. It was essentially a combined pooled analysis. And what he was interested in was different latencies. And once again, the never regular user was the referent. And with increasing latency, you get increasing risk up to an odds ratio of 3 for 25 years after first use. And indeed, risk becomes significant after as little as 5 years of use, but goes on getting stronger as the years of use increases. And this is a typical dose-response relationship we're used to seeing in studies where it's not just an association, but there's causation. Grell et al., the first author was Grell, but this was from the Interphone group. They again looked, and they'd looked at this before, but they again looked at the distribution of gliomas in relation to exposure from mobile phones within the head. And what they got was radiologists and expert neurologists to calculate the distance from the preferred ear, i.e. the ear, where mobile phones were generally held. You see what I would do. Normally I would hold a phone there. Not that I use phones. I find life is rather difficult without a mobile phone, but in fact I don't often use one. Anyway, they measured this distance carefully on radiographs, and you'll see that in females there was really no particular indication of a difference in risk. But in males, those who were within 55 millimeters, 15 to 55 millimeters of where you would hold the phone and the center of the tumor, the risk was substantially higher than those where the tumor was further away from the place where the phone was held. Again, an indication away from simple association towards causality. Now those were all largely gliomas. In addition, some of these same studies looked at risks for meningiomas. This is the interphone study I talked about before. Once again, you have an elevated risk with those who had the highest elevated degree of risk, but no appearance of risk in lower levels. And in the French case control study, we have differences in estimated risk, but none of them were statistically significant. So in the French study, they didn't find real evidence that meningiomas were associated with radiofrequency fields. The other tumor which people have looked at specifically was acoustic neuromas. You'll see on these slides it's also considered by the name schwannoma, and people use these names almost interchangeably. And here you'll see the risk of acoustic neuroma for those with a latency of 20 or more years was significantly elevated, but in fact there was significant elevation starting at 5 years from first use. Separate from the Hardell studies, there was a nationwide case control study of vestibular schwannoma diagnosed in Sweden. And this, in fact, did not find, when they looked at periods of use, a significant risk, except greater than same-side use, greater than 680 hours of use. It was borderline significant. Now those were the case control studies, and in many respects those have the strongest evidence we have. And part of the reason for that is in a well-conducted case control study you can collect a great deal more information on exposure, and therefore you can reduce the risk of misclassification of exposure. We've learned over the years, in spite of our preference for cohort studies, that in fact there is often a great deal of misclassification in cohort studies. Misclassification occurs often because you have exposure estimated at the time of recruitment, and you have no particular information between time of recruitment and the time of occurrence of the cancer. You also have misclassification because if you're asking a large number of people questions, it in fact is extremely difficult to collect data on 2,000, 3,000, 5,000 people in the detail you can in a case control study. You can give them self-administered questionnaires, but we know that self-administered questionnaires can very often include errors. The Danish Cohort Study is one of those that not only had that problem, but also the fact that when they characterized people, they did so in terms of individual use. And they ignored the fact that they had people in their cohort who were subscribers by virtue of their occupation. They received their phone paid for by the company for which they worked. But these people weren't included in the exposed group in the cohort study. They were regarded as unexposed. But it's extremely likely that during the period covered by the follow-up of this cohort, even though it's a large cohort, that the occupationally exposed people would have had higher exposure than the individual subscribers. And therefore it's not surprising that both for men and women, an update, and this is the second or possibly the third report on this study, still find no evidence of increase in risk. The other cohort study for which reports were issued in this time period was from the Million Women Cohort Study. Now this is a very large cohort collected from women who were recruited into the UK breast screening program. And Valerie Burrell, who initiated it, used the opportunity of that recruitment to collect a certain amount, quite a bit of data on a number of things. And they did have 2 questions on mobile phone use. And when you look at the question they asked, did you ever use a mobile phone, then you don't find significant findings for any of the cancers. If you look at duration of use, however, for acoustic neuroma, they did have a significant increase in risk. Now they tend in their report to underemphasize this, but it does certainly suggest that in this particular cohort study, at least for one of the cancers of which we're concerned, the cohort study buttressed the data from the case control studies. The other approach that people have adopted is to look at trends in cancer incidence. Our expectation is that any change will be slow and the risk, if there is any, will be small. Because what we're dealing with is, in the light of risks in people, is a relatively low absolute risk. You may have a high odds ratio or relative risk in the heavily exposed group, but they've, in the case control studies and in the population, tend to form a very small proportion of the population. So when you're measuring incidence, it's not surprising that any increase in risk would be submerged. There's also potential confounding for brain cancer. We know there have been trends in diagnosis. There's been increasing tendency to identify that the fact that someone who's got a cerebral hemorrhage, in fact that cerebral hemorrhage came from a brain cancer, not from a hemorrhage in an artery from cardiovascular disease. There's also the issue of latent period. As you've seen already from the case control studies, there's suggestions that this could be prolonged. So we have to look at these with a certain amount of concern. There have been studies in the US, UK, Australia, Israel, and the Israeli study showed increased risk for parotid gland tumours. The 2 Australian studies had contrary results. One of them, which had a lot of publicity, claimed to find no evidence of increased risk. I'm not going to bore you with showing you that, but some of us here have criticised that study, as have others, including epidemiologists in Australia. One of the UK studies has shown an increased trend in temporal lobe gliomas, which you would expect in terms of any effect on cancer incidence. But here is a summary of data that was published fairly recently in terms of temporal lobe glioblastoma multiforme, the most malignant, and you see the APC for Los Angeles, California, and the data from the National CER12 registry show significant trends of increased risk. And if you look at this in terms of the frontal lobe, however, you also show this. Now that's a little contrary to what one would have expected. one would expect the trends to be less for frontal lobe than temporal lobe, but I show it for what it is.
Tony, just a point. People who have modeled glasses, metal glasses, have said that sometimes exposure gets changed, and that could account for the fact that it would be deflected or altered in some way so that you would get frontal as well as temporal.
Okay, that's a good warning. So if I do use a cell phone, I should take these off.
It's just one of those potential confounders.
Yep.
Okay.
Okay. Well, they weren't collected. But certainly, those. Thank you, Deborah. Those data were not collected.
It's a lot of fun.
There have been a series of case series. We're going to hear some of them today in the next speaker, and also in the epidemiology group. The ones which have concerned me most are the reports of breast cancer. It's unfortunate that this hasn't been further pursued. I put there 7. I know there have been far more than that. Sorry, that's the wrong way. Those 7 breast cancer cases that were reported in detail were negative for genetic risk factors. There was no family history of other risk factors. It was an unusual location of multifocal tumours where the phones were kept. There was no significant histology away from the areas of cell phone use, and there were 2 with metastases. So my overall conclusions are, when I look at all these data, I would conclude that in terms of the IARC classification, that radiofrequency fields are a probable human carcinogen, IRC category 2A. Now we're going to hear information on mechanistic data in this Congress, and we know we've already heard data on the animal studies, and altogether, if the mechanistic data correspond with the animal studies and with the epidemiology we now have, I think most working groups would say category 1. But we're not there yet, and it doesn't look as though IARC are going to be able to look at this or are prepared to look at it. We must remember radiofrequency fields are now ubiquitous. Even if the risk per individual is low, it is widely distributed and could become a major public health problem. And the precautionary principle, which I know we're going to discuss tomorrow, must be applied now.